Yes.
This question is for Dr. Schoser. What is a vibration platform?
As you know the power plate device. So power plate or Galileo system, there are two, and there might be more over here. I don't know about all these different types. So that's a shaking platform you can stand on or even sit on for balance, but it's more powerful than for just balance. It's really a heavy moving load, put it on your muscles. So this was developed also for decline in bone structure and function. And it was very well first investigated for space flight. So one of the big troubles in space flight is that you lose your muscles and also your bone. And this was a countermeasure for this type of muscle atrophy. And they invented therefore this platform that's a shaking, vibrating platform, and you have an amplitude you can lean on, and also the frequency of the shaking you can adjust.
Dr. Graven.
Okay, it's a question I will try to Benedikt. What is the mechanism of elevated CK in asymptomatic? What's going on in muscle? And I also have a question for Hans and Priya.
You're a good friend. Asking this very difficult question. Of course, there might be some more turnover in muscle. So you know, if you are untrained, go first up the mountain or down, especially down the mountain a year. So you have, even if you are absolutely without any neuromuscular disease, you have an increase in your CK level. The CK itself is a mitochondrial enzyme, so there's something ongoing on energy level. It don't always reflects membrane breakdown. So therefore, it could be a side membrane breakdown and necrosis of single muscle fibers, but it also can be something in the energy supply of muscle fibers. Both things are possible.
May I also say something? Yeah, because it couldn't be that in fact there is already a muscle damage going on for many years. But before a patient noticed that he loses any muscle volume, you probably already have lost about 40% of your muscle. And in my view, and that might also be that we, for example, in the adults at the end, that you end up with a situation where the muscle is already damaged over many years and in a kind of steady state.
Is already damaged. Do you mean that there is already lysosomal glycogen accumulation?
There's also lysosomal glycogen accumulation. That's what I think. But if you look at the muscle biopsies of these patients, but of course we can't biopsy all the muscles, but for example the quadriceps, you don't see a lot of glycogen. There is some glycogen, and apparently these patients still can cope in a way with their glycogen.
But if it's already lysosomal glycogen accumulation, then why not therapy?
Yeah,
maybe this is the best chance.
That's indeed a good point. But I think one of that might be if it would cost nothing and if it would not interfere with lives of patients that much, that might be the way to do it. But these are now the pros and cons that we try to balance. But
Nina, I would also like to add a comment about the increase in CK, because I know where you're leading with that is there already evidence of involvement. And now when you look at the whole body muscle MRI, you actually see patients who are ambulating, looking very good, considered, the good responder patients, and then you see so much involvement in terms of fatty infiltration already in the whole body MRI of these individuals. So I think there's a whole degree of compensation, and the question is that if we took cost out of this, then would we have looked at it a little differently? I do think that the CK and elevations of CK is a marker of ongoing damage.
May I take the chairman's prerogative to extend this line of questioning slightly differently? We haven't really heard a lot of talk today about the pathogenesis of this illness. There's an implied picture that this illness is an illness that is solely a disease of glycogen accumulation. But in fact, there is more going on in these muscles than simple accumulation of glycogen. And I think myself that the solution to better outcomes will come from an understanding of the pathways besides glycogen accumulation that are involved. Many have been described, and I think they're not completely understood, but they need to be explored. Our patients are not returning to normal. At any rate, that's my comment. A question?
Yeah, this perhaps is a little bit more of a patient or parent perspective question. And it's, you have described so many different mutations and different phenotypes and different, how much the treatment is a multidisciplinary, needs a multidisciplinary approach. So I guess my question would be, from a patient or a parent perspective, how do we know when our centers are getting it good enough? How much do we really need to be in a very specialized place, focusing on the few centers that are really doing the primary research, and how much should we be expecting that there'll be different outcomes in different places just because the patients present differently? How do we make those choices about how we go to seek treatment for our loved ones?
Who would like to take that on? Ans.
No, that is the most difficult question that you can ask. Of course, there are many ways to Rome, as we say it. I don't know if you know the pronunciation, but of the explanation. But it's really it's very important that your doctor is doing everything in a sensible way, and then I think it's okay. Of course, there is always a difference in expertise, and we know a lot about Pompe's disease, but there will be other doctors that will know a lot of other diseases. So if there is enough communication between doctors, and in fact that's also the platforms we try to generate. That's also why it's important to have a platform like EPOC, that you can exchange information and that you can decide together what's the best way to follow up on the patient, and what is the best way to do the treatment, and what's the best way to do supportive care. Is that an answer?
Another question?
My question for Dr. Kishnani. What immune suppressive protocol you are using trying to get the patient?
So the question is, what kind of immune suppression protocol are we using for the CRM-negative patients? So this has been fairly widely published by us in more than 4 manuscripts, and it's basically using a B cell, an agent that targets B cells, and then the addition of the intravenous immune globulin to that regimen is not at high enough doses for immune modulation. It's rather to help these children, because you're wiping out the B cells to prevent infection. So monthly intravenous immune globulin, and then
how much immunoglobulin?
About 500 milligrams per kilogram. And so when it's at doses of 1 gram and 2 grams per kilogram, that's when it's really truly being used in the context of an immune suppressant. This is more to help with prevention of infections. It may have an immune modulatory role, and again, the timing of when you do the IVIG to the rituximab is very, very important, because rituximab, it's a monoclonal antibody, and so you want it to bind to the Fc receptor. So if you actually give the IVIG before you give the rituximab, you'll have less benefit potentially from the rituximab. And then there's the addition also of an agent that could act on B and rapidly dividing B and T cells, and that is low-dose methotrexate. And this was work which had come out from Sue Richards' lab at Genzyme. So this combination was a cocktail that was devised by us many years ago with an idea of getting to different pathways to get an adequate response.
Thank you very much.
You're very
Yes.
Hi, I will try to express myself as better as I can. I'm French, so my English is a little bit bad, but I'll just tell a case and ask my question after. Let's say there's a child, a CRIM positive, but is in a category of a child that is creating antibodies, like a negative CRIM positive, that followed the immunosuppression protocol, that it worked very well, and then we increased the dose of the enzyme. We are at 40 milligrams per week. But the immunologist thought that it was better to continue the gamma globulin, making sure he's not creating antibodies. And then it's been, let's say, I think 8 months we're doing that. When do you know that it's okay to stop the gamma globulins? Because nobody at the hospital want to take the decision and, okay, just making sure now he's okay, doesn't create antibodies. Who's going to take the decision? Is it a try, or is it something that we know it's okay to stop or to reduce the gamma or else?
I'd like to ask Benedikt to attack that question, please.
Hi.
All right. Well, actually, it's the situation we have in a lot of other autoimmune diseases, that there is no clear-cut regime how to finish such a trial. So therefore, it's in a way always for really the situation of your patient to see if he is doing fine, so he's stable, and then you can start to reduce. I wouldn't stop right now from the complete dose. I just would taper it down and see what's ongoing. So that would be my recommendation.
So reduce
yes,
slowly
reduce and see if everything keeps fine.
Thank you.
A question in the back.
Hi. So Dr. Schoser mentioned bioenergetics of muscle being an underexplored area. I was wondering if any of the speakers had any experience of coenzyme Q10 or other mitochondrial vitamins, etc., in Pompe disease, whether it does anything.
So, in general, I could say that we do know that there is mitochondrial involvement if you look at the biopsies. But has it been done systematically? No. Has it been done occasionally using CoQ10 and others? Yes. Has it really helped these patients? I don't think we really have a clear answer. So Virginia, sorry for sounding iffy about it, but in some situations where families have, where there is extensive involvement and where you've done the enzyme replacement therapy and other aspects, one could add this, but I don't think there's any systematic study to date.
We don't have any experience with Q10, but we supplied carnitine to some patients and alanine, but it's all random, and we didn't see a clear effect.
Another question.
Thank you. It's been mentioned about adult onset problems with speech and swallowing, and I'm wondering if any of you are aware of any studies that have been done to show how to improve that, any specific therapies or exercises?
So this is work that was started by Harrison Jones at Duke, to show the swallow study challenges, and the thought is that could be related to a bulbar weakness. And then it's also related to lingual strength, and a number of our Pompe children and adults do have a tongue weakness. Even many have a lot of difficulty with even clearing food particles, etc. And so there are a couple of approaches that have been taken for the children at least. It's almost like a child with a cleft palate, where you try and use device, the palate lift to help them. But he's also using right now some strengthening exercises at our institution. So those data are not yet published, but I know that they are ongoing.
There's another question over here.
Hello. This is related to the situation earlier with the infantile onset family and also adult onset in the same family where there were several siblings. I know, I guess, would you say this is kind of some of those fluke things, 1 in a whatever, billion, or because I do know of a few other cases, but or is this something that as our infantile kids are getting older and our adult parents are still at a young age that we're thinking this is not as understood as possibly could be happening?
This is really an accidental case that can be explained, and I think that was also clear from the case that was presented that there were 3 different mutations in the family. So from different sides, mutations came. So, and I think it's very important that there is no misunderstanding that if you have an infantile patient in the family, that then suddenly also the healthy children who are now 15 or 20 suddenly get Pompe's disease. That's not logical. That's completely unlogical. Of course, there can also be always be a gamble of nature that it makes that you end with a situation like this. But I really want to stress that this is not the common situation. Do you want to say something? Because
another question.
Professor van der Ploeg and Professor Schoser, concerning the start of ERT and concerning the definition of symptom. Could you give a explanation, a near detailed explanation of symbol of a symptom under medical aspects? For instance, if you see a storage of glycogen in an MRI and the patient shows no symptom, no negative appearance in his movement, would you look this storage of glycogen only seen in the MRI as a symptom?
You want to start, Benedikt?
I start. Well, a clinical symptom is definitely something like weakness, like spasticity, like muscle atrophy, something like that. So something that is visible for you, that is investigatable for you. If you do the clinical examination of the patient, you see the ptosis, you see the macroglosia in some of the patients, you see the waddling gait and things. That is the classic you see. A sign could be just a lab value, so it could be the hypercycemia, or it could be on the MRI a special finding that there is some involvement of the muscle and things like that. Symptoms is definitely related to any type of clinical related change in the appearance of a patient.
Thank you.
Yeah, and I think we both agree that we only treat symptoms.
Yeah.
Another question?
This morning, Dr. Bach said very strongly that there is no reason for a patient to be on BiPAP or CPAP. This seems to be really contradictory to what most of us understand. Can you just speak to that some? It's not kind of fair because he's not here to answer for himself, but what is the traditional approach? I mean, is he ahead of the game? how do we make those decisions if is there consensus, I guess, among everyone about BiPAP, CPAP, those sorts of things?
All of you may answer that question. Should answer that question.
I think we all are not really the pulmonary experts, so we also have a backup team for these types of decisions. And I think we all have a home ventilation team that makes the decision. But in fact, there is mouthpiece ventilation is used by a lot of people, but also a lot of people use, most people use BiPAP during the night. From a personal point of view, and I think that's the experience, if you could postpone the placement of a trachea cannula, that would be really good. So, but now and then we are also confronted with situations that patients suddenly get in respiratory failure and that they can't wean from the ventilator, and then mostly you don't have any choice in our experience. But that's what we experience. I don't know what you.
Yes, so I can comment on this a bit more. So CPAP ventilation is perhaps the most non-insufficient ventilation you can use. So CPAP is only for people that have some snoring at night, things like that, but they don't have really ventilatory disturbances of the diaphragm and also the extra ventilation muscles. So BiPAP is very useful, and it's absolutely, if it's a fitted mask, it's absolutely similar to a tracheotomized patient. You can do it really one-to-one. You can fully ventilate a patient for years. There are a lot of studies out there, and we know that pretty well from many patients with ALS. So there's no need for tracheostomia in many of the patients, not in all. There are exceptions, of course, as usual. But therefore, I don't completely agree on this, that we should try to, if someone is already ventilated via tracheostoma for years, of course, this is still possible that you can go back to non-invasive ventilation. Of course, there's always those patients who have the chance. It's a long way to go normally. It's not something that's doable within weeks. So you sometimes need months where you have both devices on it and things like that, and you need a rehab setting. You can't do this in an ambulant patient and things like that. So there needs a lot of experience, and of course, Dr. Bach will have this, and he can do that. But the most of the rest of the world won't try to do that, to be honest.
Any other comments?
I just wanted to add one more comment. The role of CPAP versus BiPAP is, as Dr. Schoser also mentioned, there are different scenarios when they are used, but even the level of bilevel ventilation that's used really needs to be titrated very carefully, and often needs an overnight sleep study with a pulmonologist or a neuromuscular specialist or a combination to make sure that the right settings are available. So I think that non-invasive versus invasive is another discussion, but I think the use of bilevel ventilation is very important in individuals with Pompe disease.
Yeah, I'd like to comment on that a little bit, because I've heard Dr. Bach's presentation several times, and I don't think he's ever recommended no ventilation. His comment is more, CPAP is really not appropriate in the majority of Pompe patients, but as to BiPAP versus volume ventilation, he's more in favor of volume ventilation, unless BiPAP is used appropriately, as Dr. Kishnani said. But he absolutely understands that Pompe patients require ventilation. He just advocates non-invasive ventilation.
Yeah, and I think that is absolutely in good agreement with all of us. So that's really makes sense.
People, you know everything.
Can I make just a quick comment? Stephanie Austin from Duke, who gave the genetic counseling. I just wanted to comment one more time on the seeing the late onset and infantile in a family. That was mostly to point out that we should be looking very closely at these families, because we actually have 2 other cases also at Duke where we had a infantile patient diagnosed, and then later the parent was diagnosed with late onset. So in that family, if that mother had continued to have children with the same partner, we potentially could have seen other late onset children in that family. We also have another family where we have a child with infantile onset and then a second cousin with late onset, 2 siblings with late onset. So I think as we do newborn screening and we find these patients over time, we might continue to see more patients.
Question over here.
Dr. Rabin, I'm calling on you. Oh, excuse me, there's another question.
The newborn screen, is it widely done in all 50 states in the United States? In which states are they doing it?
So the state of Missouri, actually, Missouri is already ongoing. New York State is ongoing. Pennsylvania has started. And I think there are other states that have received pilot grants. I think Georgia, New York is one of them, and Washington. Michigan. So
and do they do the dried blood stain
Yes,
test?
it's done as part, because dried blood spots are used for other aspects for newborn screening. And so using that same blood spot now for doing lysosomal enzyme testing for Pompe is the add-on.
And will it say lysosomal or will it say acid-maltate? I mean, do you know how they list it?
For the states that are doing it, it would be called for Pompe disease, so acid alpha glucosidase deficiency. And as an update, it was recently mucopolysaccharidosis type 1, which is another lysosomal disorder, is now awaiting the signature from the Secretary's Advisory Committee, and more recently adrenoleukodystrophy was also nominated. So I think the field has opened for the rare diseases, including the lysosomal disorders.
Yes, in far corner.
I have a quick question. I heard a couple of you talk about the wait and see method. We have a non-classical infantile baby, and he started having allergic reactions to the drug, and they stopped infusion about 30 days ago. And so we're just trying to find out what the wait and see approach is for a non-classical infantile baby that actually does have symptoms.
May I say something about it? And maybe then you could also respond. In our experience, we rarely encounter a situation that we can't handle infusion-associated reactions. So, and if your patient or if your child is really, clearly affected at a very young age, it's very important that the child continues to use enzyme replacement therapy. So that's my view, and find ways to do it.
Jenny, I would agree with that statement that we typically are able to get around the challenges with infusion-associated reactions. And to date, we've not really had to discontinue enzyme replacement therapy because of a risk of hypersensitivity reactions. And so if the child is symptomatic, as even Dr. Vanderpook says, I think one has to find ways to go back and treat.
We have very good experience with starting very slow infusion rates, and that now and then seems unlogical because you start the slow infusion rates far before the infusion reaction starts, but that helps to prevent the infusion reaction later and fever. So
we only get to a certain amount, it's like 0.25, and then we go to 0.50, and we're already done. So
Yeah,
that's the issue we have. And then the microdilutions, we've already done that. And then the different pre-medications, we've done all that. So I know there's different approaches, but I just feel like we're missing pieces to it. And he doesn't have antibodies at all, and there's no immune-mediated response as well.
Yeah. we have also experience with the child, and I'm looking at Henrike because we all both know the child, but I think it happened in another child that with the first drop of enzyme there was an infusion reaction, and we simply didn't understand why it happened. But we managed, and at a certain moment it stopped, and then it was okay.
Thank you.
Yes.
I actually just had two comments. One for, I think it was Dr. Nina, about CK levels. When I first hired on with my company 30 years ago out of college, I was getting ready to go overseas, so my company did a physical, and they checked my blood test, and my CK levels were through the roof. And they thought maybe I was an alcoholic or something, so they did a bunch of liver tests. They said, your liver's fine. They said, well, okay, you have no symptoms, so we'll let you go overseas. So 12 years later, overseas, I come back home, and still everything's fine. I water ski, snow ski, golf, everything, no problems. Now, people did say I ran funny around the bases, but to me, that's just, I was fine. And then when I hit 40 years old, it was like the wheels of my wagon fell off. And I started having all kinds of problems. I was waking up in the mornings with headaches and all kinds of problems. And they finally diagnosed me with sleep apnea. And then about 45, I finally got diagnosed with Pompe. So I think the CK was something early going on that didn't show up until finally my muscles got old and couldn't overcome the damage that was being done. And then so I've been on this ERT since the trial before it was approved, and it's so much better now. My second comment is about your doctor versus going to the experts. I love my doctor. He's the one that figured it out, because for many years I knew I had a problem, but it wasn't until I went to see this doctor that put it all together. So I love him to death. I don't want to go over his head, or seem to be going over his head by going to the experts. But when I come to a conference like this, and I know there's so much more that we could be doing, that I'd like to at least tap him into that. So I want to try to do that. I want him to learn along with me, you know? So I guess it's a fine line between being satisfied with the doctor you have and tapping into the experts. Because quite honestly, my doctor only has 2 Pompe patients, so I can't expect him to be the expert on that. Thank you.
Nice comment.
I had a question, but I kind of want to respond to that because I thought that was great. I think being that we are at the experts, I'm very fortunate. We weren't at the experts, so we went there. We're close enough, fortunately. But I've talked to so many families over the 9 years that aren't at the experts or maybe have a good doctor, kind of like you. And I just feel like even though you feel like you're going over their head, they may feel that way or they may not. But ultimately, if they're a really good doctor, they're going to care about y'all's #1 well-being and wanting to be better, and so it won't matter. And if they don't, then you probably need a new doctor. But they, at least go see the other ones and just tell them what you've done, and at least that way later on you've done everything that you could to, whatever it is. But that was just my 2 cents on that. The other question I have is, what was my question? So I know in the infants there's the heart muscles, obviously, when they're severely affected, and then on the myozyme or lumazyme, they're different than the skeletal muscles, so they repaired at that point. Now, in seeing some of the pictures with the children, I don't know if it was is it Chien? Some of them with the open mouth and tongue protruding out, things like that. Now, and I see pictures of Haley when she was younger, and at the time that was normal to me, and she definitely had that. And now she sometimes still does, but she's got very good mouth closure, probably because she talks a lot, but she, good mouth closure, her tongue doesn't stick out, things like that. Is that something that, I know it's not like the cardiac muscle, but why the repair so much better for that, even the ptosis of the eyes? And how can that be related to trying to get the skeletal muscles repaired at some point?
First, I think that every group of muscle have different response to the treatment, and I also think that exercise is very important. So now, every our patients need to go to see a speech therapist to do those oral training and even do some stimulation or the speech therapy. So I don't know if in the future the muscle will be deteriorate, but I think that adequate exercise is very important.
I don't know if I heard your question completely, but I think it's very difficult to. It's a very complicated situation in the mouth, I must say, because what you have, there is the big tongue, but there is also the closure of the palatum that closes the nasal cavity and the nasal pharynx, and if you have there leakiness, for example, if the palatum doesn't close completely while you speak, then you get leaky. Then the air leaks through your nose, and that's how you get a nasal speech. What we hear more frequently from patients and also in adults, that the tongue becomes less thick, and of course that may help in getting a better pronunciation. And then you have the swallowing, and the swallowing are the lower muscles. So, and then you have the face. Also, the face is there can also be facial muscle weakness. So it's a very complex group of muscles that are involved, and it depends which muscles are most severely affected, and that also that determines the effect. In our experience, the infants frequently have speech problems. With the older children, I have currently a child with really this type of expression, but we don't know yet how it will evaluate. Do you have any experience? The two of you? Yeah? With what happens with speech and mouths and the older children?
It's pretty similar. We've actually seen some speech dysarthria even in adults with Pompe disease, and I think that's much more when we see it is when they have severe lingual weaknesses. I think when we've really noted that, or swallowing difficulties, telling us that there is maybe a component of bulbar muscle involvement. As far as the atypical or the non-classical infant, they may have some hypernasality, but it's not to the same degree as the child with classic infantile, and they're definitely more understandable and respond very well to speech therapy. The classic infantile also do, but they require a lot more work. But I'm curious to hear from Nancy, for the ones that are started at via newborn screening, are you finding that the speech and articulation is still similar to what you were seeing in those that were clinically treated?
Yes, actually, I think there are several kids here. They just speak like our newborn screen cases. So I want to add a little comment about the elevation of CK, because in our newborn screen cases, although we find they have the late onset the late onset genotype, or they don't present cardiomyopathy initially, we follow them, and several of them have elevation of CK. And thank for Dr. Reben's help, we do the muscle biopsy before treatment and also after the treatment, the 6 months of treatment, and we do see glycogen storage even after the treatment. So I think that there are still some work we need to do to define the best initiation time to do the treatment.
Thank you. Yes.
Hi. When I was diagnosed with Pompe in 2011, I was 61 years old, and at the time when I was diagnosed, my pulmonary tests were good, perhaps above normal for my age, and so almost immediately I was identified as having obstructive sleep apnea. I have been on a CPAP since then, and yet at the same time, when I travel without it, it doesn't seem to have any negative effect on me. So I'm sort of wondering, like, I heard from Tiffany before that, I mean, Pompe, you shouldn't be using a CPAP machine at all, and I'm just wondering, like, I've learned an awful lot at this particular conference regarding a lot of myths that I seem to have been told by various different specialists, and it leaves me more bewildered than actually I was before I came, because now I'm really questioning a lot about my own diagnosis.
I'm going to pass this to another question. You have a room full of experts here, so. Yes.
Oh, hello? Okay. Dr. Schoser, you had said in your exercise recommendation 80% endurance and 20% strength training. Is endurance aerobic exercise, like walking or cycling? And then do you have a target heart rate that you would recommend for that?
It's definitely aerobic exercise you should do, and of course you can use whatever you like. So don't be ridiculous and just focus on one thing. So you can cycle, you can walk, you can swim. So whatever improves really your endurance, that is good. If you go hiking, so that would be also fine. And the heart rate should not increase 25 to 30% over your normal heart rate. So that could be a good limit you can have for yourself. So it's rather easy to track. And you know, we don't need extra devices and things. You all carry your mobile phone with you, and you can get all the information in there. So there's no need for an extra device.
Another question. Yes.
In Canada, we quite often follow the lead of the US in a lot of areas, and newborn screening is one of them. So now that Pompe has been added to the recommended panel in the US, and thank you, we've started making submissions to the health authorities in Canada. Dr. Chien, I noticed that you said that a new report would be coming out in 2015, I believe. I think you mentioned that there was going to be a report coming out sometime in 2015. I don't think it specifically said what it was, but...
No.
Oh, was it Priya?
I know what I mentioned.
Oh, sorry.
There is a newborn screening supplement coming out in pediatrics, and this is basically for trying to develop some guidance around newborn screening. You know, how do you follow these patients? When do you really initiate treatment? What are the minimum sets of tests that should be followed or could be done over time, those kinds of guidances. And so this was with a group of experts from all over the world who have experience in newborn screening. And that's in the final stages of completion. I think it will be a very useful document because it goes through different scenarios. And of course, it's a guidance document, but it's a whole supplement, and the editors from pediatrics actually welcomed it, so I think we are fortunate.
Is it close to being issued?
Yes, yes, yes.
Okay. Thank you.
Now, this is a question about the dosage. What do you think is the possible upper limit? Because this is quite an arbitrary dosage. 40 mg per kilogram twice, once a week, rather than it's like 4 times more. So why not to go to 100 or whatever?
Now, this is of course. I think, of course, you have to be realistic, and we came up with a dose of 40 mg per kg. We discussed a lot about it. We didn't do it on a one-day decision. We did a lot of discussions on it, and in fact, it is the dose that we also applied in the later stages in the rabbit trial. And we also made a calculation based on PK, but I couldn't show it today because it takes too much time to show it. But if you draw a graph and you look at the what happens with a dose of 40 or 20, then you can reason, and that has also been shown in the mice, and I think you also did these type of experiments, that in mice there is a linear kind of curve how the enzyme is taken up in the muscle. Then you can also reason that if you give double the dose, you get twice the activity. And if you give 1 week interval, then also if your half-life is 7 days, then also your level is lower.
Is the absolute limit? Or
No, I don't go higher. No.
Yeah. Nina, I would like to comment on the upper. I don't know if we know the upper limit, but clearly we have seen nephrotic syndrome when we've done very high doses of enzyme treatment in the trials. But this was in the setting of the children who also had the high antibody titers, so it was to avert that. But we did see reversible nephrotic syndrome in them when it was being done at about over 50 milligrams per kilogram per week, but do remember that there were other factors going on with them. So the 40 milligrams per kilogram every 2 weeks was actually part of the pivotal trial for 1602, where half the children did receive it. So we knew that 40 milligrams per kilogram was a safe, tolerated dose, but this was at every 2 weeks. But I think we also understand from other enzyme therapies that not one dose is a final dose. Even if you look at the data from Gaucher disease, the label says 60 units per kilogram every 2 weeks, but then there are variations to this. So just
dosages are much lower. They're 100 times less.
Yeah, but
absolutely, absolutely. But then this is also targeting skeletal muscle, which is 40% of your body weight, and you've got inefficient delivery to the skeletal muscle with the potential that you have M6P receptor drop-off with time. So to answer your question, at least from my standpoint, the 40 mg per kg every 2 weeks was based on preclinical work, also based on clinical trials, and then the reason to go up even more was based on the fact that the children were still showing plateau and decline, and that seemed to be a safe and acceptable range without having the side effects of nephrotic syndrome and also the duration of the infusion as it stands right now.
If I may make a remark, I think you should not refer to the nephrotic syndrome, because these children, I don't know what kind of treatment they got, but they got daily doses, daily very high doses, with an enzyme preparation which is no longer being used.
They were getting 10 milligrams per kilogram per day, 5 times a week.
Every day, and how many months in a row?
No. So it's the
and the quality of the material that was used in those days.
Can I just finish? So this was using the material that was ultimately developed at Genzyme, but it was 10 milligrams per kilogram per day, 5 days of the week, and after 2 months they developed nephrotic syndrome.
Yeah, it's not the right example, I think, to here discuss. It's not the right example to discuss in when we have it about dosing, you know, this was really very exceptional.
No,
And
no, I think agree with you.
We should forget about that study.
But that's what the FDA does bring up every time that it's talked about, and so we have to go with some of that FDA guidance as well. They look back at those publications.
Another question, or are we at the end? We're not at the end.
I have a question for the German doctor. When I begin the therapy, I was walking, and now I'm on a wheelchair. And you said that if you don't see significant effect after 2 years, you decide to stop the therapy. But how you can decide that the patient could be worse if you stop? Worst of the worst, because I'm on a wheelchair, but I could be on a ventilator or on a bed, I don't know. So how you can decide?
Very good question, actually. We don't stop. We never stop the patient, but at least we start a discussion if the patient is still feeling well, having no, for him, meaningful change in under treatment. And therefore we have to discuss this with the patient if he still agrees to continue or if he wants to try to stop and whatever. So that's the discussion starts, not the stop of the treatment. No. Yes. It's a shared decision. It always should be a shared decision, and that's the thing we can continue, especially in those rare diseases, chronic diseases. It should be really a shared decision, and both sides should agree to really find a solution of that.
Yes.
Hi, my name is Stephanie. I'm from Duke, and I help with the infusions for Pompe disease. And I'd be interested in knowing from the panel and any other treating physicians, and also from the patients, what is the maximum rate that you infuse the infusion? Do you go beyond the 7 mg per kg per hour? Because we're starting to explore that for some of our patients, but I'm just wondering what the experience is.
I find it very difficult to recall that now right by head. Do you know, Hanrike, exactly what is maximum infusion rate? Yeah, okay. But I know that we have experience in the past with giving it faster, but I can't recommend it at this moment. I think you can go quite fast at the end. I think that the problem is at the beginning. You have to start slowly, and once you're up higher. I think it's not really a problem. Yeah.
One comment from my side: if you increase it a lot, so you got the trouble with the filter. So the filter is always stuck, and that's the limitation factor in that. So you can increase the infusion rate. I think that's possible in patients that are stable, but then you have to be very careful about the filter setting, and that's the limitation in my eyes and in my experience.
I see the boss.
Hi. I'm really sorry to do this, but we are far over time at this point, and I know it's hard to believe, but it's after 6 o'clock. We've been at this since 7, so I mean that's an incredible 11 hours of learning and discussing, and I want to thank all of you for your stamina, for bearing with us. I want to thank the speakers, the patients, just everybody for being here. Couple of more announcements. From 7 to 9, the AMDA is hosting a reception for the patients, a Halloween reception, so grab your costumes. And it's going to be on the restaurant level at the restaurant patio. There's also riverboat rides, so if you haven't signed up for those, find Marcia and sign up for them. And for the speakers, we will be meeting downstairs at 6:30. So hope to see everybody and have a great evening.